Thank you for the intro. So like the chair mentioned, I could talk about some of our recent work to map the stiffness within carotid plaques by combining plane wave ultrasound with our established pulse wave imaging framework. So I think the first two speakers gave a pretty good intro on why we want to image the carotid artery. The point that I want to make is that carotid artery stenosis, it can cause a stroke, which has a staggering death rate worldwide. And also the key statistic here is that 80% of these cases are in patients that are asymptomatic and have had no history of stroke. So a large part of that is that currently in the clinic, the risk of stroke is predicted by the degree of luminal narrowing, which is not a really good predictor of stroke. Moreover, there's been a lot of research that have said that the composition and the morphology of plaques is a better predictor than the degree of luminal narrowing. More specifically, very generically, plaques can be classified into stable or vulnerable. Calcified plaques, which tend to be stiffer, are indicative of more late-stage and stable plaques, whereas plaques that are higher in lipid content, they tend to be softer and more vulnerable and prone to rupture. So there's a lot of methods that perform different measurements regarding plaque assessment. I'm listing a few of them here. CT, NMR, angiography, they strictly measure the percent of stenosis. And then a duplex ultrasound exam, which is also used clinically, measures the flow waveform, the flow velocity, and uses that to correlate to the percent of stenosis. Also, in terms of ultrasound imaging, RFI typically uses induced peak displacements and the recovery time to assess plaque characteristics. Also, non-invasive ultrasound elastography can use the 2D wall displacement and the strain, which is caused by the natural pulsation of arteries to characterize plaques. And finally, PWI, which is a method that we developed in our lab, it measures the pulse wave-induced wall displacements and also the pulse wave velocity, and potentially can use that to characterize plaque properties as well. So some of the previous work that we've done with the method, we've done Vivo studies in mice with abdominal aortic aneurysms. We've done validation in phantoms, and we've also done feasibility in normal human aortas and carotid arteries as well. So in all these methods, typically what we've done is use 1D normalized cross-correlation method to calculate the axial pulse wave-induced wall displacements. So here we're showing the overlay of the posterior and the anterior wall displacements onto the B mode. And as the artery dilates, we can see a wave that propagates very quickly across the image segment. So then once we have this motion, we can map, for example, the motion in the anterior wall only if we look at a single wall trace through the wall. And then we plot the displacement waveform over time at each scan line position. We can generate a 3D map of the wall displacement over time for each scan line. So if you look at this map from the top, essentially a space versus time map of the wave propagation. In the past, we've done a regional pulse wave velocity estimation where we track the 50% upstroke of each waveform, we take linear regression, the entire image segment, and then we estimate the pulse wave velocity throughout the entire piece of the artery. If we want to get more specific, for example, if we want to image carotid plaque, which is a regional inclusion, we can use the kernel and slide it down across the map, generate an array of pulse wave velocity values that kind of shows how the velocity is changing. So in a normal carotid like this one, we expect to see very similar pulse wave velocities along the segment. If we have a carotid plaque somewhere in the middle or towards one of the ends, then we would expect to see a disturbance in the pulse wave velocity distribution. So for this particular study, we used a window length of 7.5 millimeters, and then we slide it one point at a time across the image segment. So before getting into like the specifics of this study, I just want to go over our framework, Intra-Plaque, PWI. So essentially what we're trying to do is image inside of plaques rather than taking a trace through a single depth. We can isolate, for example, this plaque region here. Here I'm showing two plaque regions shown in red. If we isolate one of them, you see these blue lines. We're generating multiple wall traces throughout the depth of the plaque. And then for each trace, we can generate a map of the wave-induced motion. So if we take a piecewise pulse wave velocity estimation for each wall trace, and then we overlay that onto the B mode, we can generate a map essentially of the pulse wave velocities along each wall trace throughout the depth of the plaque. Other things that we can do, since we've segmented out these plaques as regions of interest, we can track the speckle within the ROI. So we're essentially accumulating the pulse wave induced displacements within the plaque ROI over time. And then if we take the maximum cumulative displacement, that corresponds to the displacement of the maximally distended artery. So we generate a map of the cumulative displacements as well. From there, we can take a least square strain estimator, calculate the cumulative strains. So we can also estimate the distribution of strains within the plaque region. For the kernel size, we varied it depending on the thickness of the plaque. So for thicker plaques, we use a larger kernel. For smaller plaques, we use a smaller kernel for the strain estimator. So these three measurements here, the PWV, displacement, and strain, are three metrics that we use that we can potentially use to characterize inside of plaques and potentially investigate the heterogeneous nature of plaque composition. So for this particular study, we wanted to investigate the feasibility of these methods in moderate to severe cases of stenotic carotid arteries. We studied 5 patients. They were all male. 4 of them were undergoing a carotid endarterectomy, so we were able to obtain the specimen that was resected during surgery and also use that as a source of validation. So the specimen that was resected and the B mode and also the CT angiogram that we obtained for some patients, we use those to grade the degree of calcification. So that will become more apparent as I show results, but there are characteristics that we can use from the specimens, the B mode image, and the CTA to kind of correlate with how calcified the artery is, so we can expect what the stiffness will be. We also perform the same measurements in 5 normal carotid arteries. We try to age match them as best as possible, but then there's still a significant age difference in the groups. Imaging system, we use plane wave with a Verisonics Vantage system. Imaging parameters are shown here, and then we use a delaying sum to reconstruct 128 scan lines. Basically, our overall hypothesis is that in plaques that exhibit a greater degree of calcification, they also exhibit a higher PWV and a lower strain and displacement, which are indicative of an increased stiffness. So now let's look at some cases. The first case is the case that I showed in the method slide. We have these 2 regions of plaque here that are shown by the red arrows. There's a greater degree of shadowing here, which suggests that the plaque towards the distal end is more calcified. And that's verified by the fact that the wave appears to propagate through this plaque right here, but then it kind of stops here due to how stiff this region is. If we look at the CTA corresponding to the same imaging location, we can see that the plaque that appears stiffer is a lot brighter, suggesting a greater degree of calcification. And also the acoustic shadow that's cast by this plaque, it occludes the imaging view on the ultrasound here. So we focus on the plaque through which the wave propagates. We can identify 2 regions, 2 bright inclusions, which suggest regions of calcification. So we look at the Intra-Plaque results for displacement, strain, and PWV. This is very hard to see, but there's a slight decrease in displacement where we expect the inclusions to be. And on the strain map, that shows up as blue, which suggests that the tissue is compressing. And then in the PWV map, in between where we expect the inclusions to be, if you follow the depth of the plaque where the red arrow is, we can see that the regions of the PWV is alternating between positive and negative. So the color map here is from about -6 to +6 meters per second. So in between where we expect the calcified inclusions to be, we get this region alternating positive and negative PWV throughout the depth of the plaque. Second case here, we're imaging the common carotid artery. And if we look at the CT, we can see that the bifurcation is very calcified, which leads to some shadowing towards the distal end. But we're imaging where the yellow box is. So here, we also see 2 bright spots suggesting calcified inclusions. This particular patient, we were able to obtain the specimen during surgery and do some staining to confirm the calcifications. So we stain these 2 segments separately. Then we can see the 2 calcified regions on the H&E stain. So we look at the Intra-Plaque results. Also, we see a very faint decrease in displacement where the inclusions are. Now it corresponds to regions of tissue elongation, approximately where the inclusions are. And also on the PWV map, again, we see throughout the depth of the plaque alternating negative and positive PWVs that seem to correspond to the locations of the calcified inclusions. This next case is a highly calcified case that we image of the carotid bifurcation. So in the yellow box is the plaque of interest. It actually shows very high displacements as the wave propagates through. If we look at the CTA, this artery is by all accounts is 99% occluded basically a computer occlusion that's verified by the gross pathology of the specimen at the bifurcation. So we see this white nodule here, which signifies a region of very severe calcifications. That causes an acoustic shadow shown by the pink arrow. An acoustic shadow that essentially blocks everything underneath. So we see this large black area. If we look at the Intra-Plaque results, we see a distribution of displacements, where in this end here, we see high displacements, and then in this region here, we see lower displacements. So there's essentially a gradient of displacements within this calcified region. Strain, it actually doesn't vary too much. We see some regions of compression here, and also towards the end here. Also in the PWVs, similar to the other two previous calcified cases, we see a region where we have alternating positive and negative PWVs throughout the depth of the plaque towards the distal end here. With this last case, it's a very similar imaging location where we have a bifurcation and then a plaque that extends into the internal carotid. So if you look at, if we zoom in on the region here, this plaque actually exhibits characteristics of a lipid plaque. So on the B mode, we can see this echolucent region in the middle here that's surrounded by echogenic boundary, which signifies a fibrous cap. And then the gross pathology from this patient on the specimen that we observed, this very fluid-like gooey substance that's like a necrotic fatty substance that was oozing out from this plaque during surgery when it was resected. Also, we see on the posterior wall plaque here, we have a bilateral plaque on the top and the bottom walls of the internal carotid. See this very calcified nodule here, which likely caused the shadowing that we see on the B mode. So now for this case, Intra-Plaque maps, our displacements are actually pretty uniformly distributed. And then if we look at strain, it actually seems like it can reveal the fibrous cap and then the carotid core as well. So here, the fibrous cap appears to be compressing, and then the carotid core appears to be elongating. So we can separate the two regions here. The PWV map, again, we see a large region of negative PWVs and also a region of positive PWVs. Unlike the previous calcified cases, if we go down the depth of the plaque, we don't really see any alternating positive and negative PWVs. So along the depth direction, the PWV is pretty constant, which is not what we saw in the previous calcified cases. So just real quickly, some quantitative results. The green bars correspond to the five normal carotids that we imaged. So this is the right and the left. And also the blue bars, they correspond to the moderately calcified cases with the two calcified inclusions. And then the red bars, they correspond to cases where the calcification was very severe. Finally, the orange bar is the lipid case. So there doesn't really seem to be too much correlation between displacement, strain, and PWV. For example, in the cases that are red, that are very calcified, we expected to see much lower displacement, much lower strain, and much higher PWV. But then, contrary to our hypothesis, highest PWV here was shown in the lipid case. So there's a lot of factors that we'll be discussing in the next slide. Just real quick, 2 points I want to make. We saw positive and negative PWV in all plaque regions in the cases that I showed. That could be attributed to things like turbulent flow and wave reflections around the plaque regions. Also, the waveform morphology is changing if you have a regional inclusion. As the wave is propagating, the shape is also changing. So it becomes very difficult to track the wave if there's a regional inclusion. Finally, there's a lack of correlation between our quantitative measurements and the expected stiffness. A few factors that might have caused that. The carotid imaging could be location dependent. So for example, the cases where we imaged in the bifurcation, we could have saw some increased strong cingulary motion that's been observed in literature. Also, strain estimation in the carotid wall can be very noisy because we're imaging a very thin structure. And finally, our lipid case, which exhibited the highest PWV, was also, the fibrous cap was very thick, suggesting that this is actually a late-stage plaque that was also very stiff as well. So there's a lot of factors involved that may be able to explain the results. Finally, our conclusions. We identified a few features using Intra-Plaque PWI that may be able to reveal Intra-Plaque properties, namely alternating positive and negative PWVs along the depth direction to be observed in cases that were calcified, but not in the lipid case. And also with Intra-Plaque strain maps in the lipid case, we were able to separate the core from the fibrous cap. In the future, we want to increase sample size, study more vulnerable plaques, validate with simulations and phantom experiments, and one of the things that we're doing with that is the potential to calculate modulus maps. So if we know the PWV, we can also measure the diameter and the thickness. We can derive the modulus using the modified Mohr-Quarterweight equation, which makes a lot of assumptions that might not hold in vivo. So along those lines, here I'm showing 2 modulus maps from the previous cases. So along these lines, we're trying to build on this equation and create like a more realistic theoretical framework for deriving modulus. Okay, I'd like to thank our funding sources, our collaborators, and my lab at Columbia University. Thank you.